Hello, can anyone hear me?
Mr. Obina. Yes, Mr. Obina, we can hear you.
Yeah, thank you very much, Dr. Raf. Please let's see if we can quickly share the links among all our contacts so that more people will join. We have just close to 20 people that have logged in now, and we're expecting over 100 participants. So I would appreciate if we can quickly reach out to everyone. I'll share the login on our on the chat, on the general chat room, and then we can share with everyone we know. So we'll be streaming on YouTube and on Zoom where we already are now. So that's the login. So meanwhile, I want to say welcome everyone. Thank you. If you're just joining, you can just say hello on the chat box. For those who are just joining. All right, so I'll start up now. Good morning, everyone. Thank you once again for joining us on this webinar. Today, we'll be discussing a very important topic that has to do with you and I and everyone, and of course, those whom you care about, diabetes and hypertension and your eyes. Okay, and this is brought to you by EHA Clinics in collaboration with LECC, one of our newest partner, that is Lagos Executive Cardiology Center, and we'll be collaborating with them to bring light and shed light on this all important topic. Right. Today I have two speakers. All right, Dr. Raphael James and Dr. Udu Ikem Gabriel. So Dr. Raphael James is a licensed optometrist with over 5 years experience providing eye care in both clinical and community health setting. He currently works as the optometrist at the EHA clinics at the Kano location, where he offers comprehensive eye examinations, patient education, and management of common ocular conditions. Right. In addition, he serves as the optometrist to what we call REACH at EHA clinics, which is an acronym for Reaching All with Accessible Community Health. Right, and it's a community outreach initiative that is focused on bringing quality and accessible eye care to underserved populations. His work has been driven by passion, preventive eye health, especially in the context of systemic conditions like diabetes and hypertension. You're welcome, Dr. James. Please say hello. Can we look at your face again?
Hello, everyone. Thank you for introducing Mr. Obina.
Yeah, glad to have you. And then our next guest is we thought we just met a couple of hours ago, is Dr. Udo Gabriel Ikem. He's a renowned primary care physician at the Lagos Executive Cardiology Centre, LECC, with expertise in managing chronic conditions such as diabetes, hypertension. Dr. Ikem has established himself as a trusted gatekeeper in cardiovascular care. He has been involved in numerous research papers widely published in prestigious medical journals, and is also passionate about public speaking. All right. When not advancing medical knowledge, he enjoys playing badminton and football. Today, he'll share his clinical insights on the critical intersection of diabetes, hypertension, and eye health. Thank you, Dr. Ikem. Please say hello.
Hello, everyone. Good morning.
Thank you. You're welcome, Dr. Ikem. So just a little ground rules. Like I said, you can invite anyone to this webinar, family, close friends, those who will be needing this care. Primarily, our target are those who directly need this. At each clinics, we run a program called the empanelment. Okay, so these are individuals who may have been diagnosed with any of diabetes or hypertension, all right, and now need care. They are usually um, they're usually distributed among some of our clinicians here at AG Clinics, and then we do a monthly follow-up to see that they are, they are compliant with their drug regimen. They are observing their blood pressure, they're observing their blood sugar, they're taking their medications, making sure they have their constant refills, they're doing their annual eye check. We're doing all of these things to be sure that they do not degenerate beyond where they currently are, if anything is an improvement, right? So they are also our very special guests to this program. So I feel like if you find this valuable, I think you should reach out to as many that you think you love and you care about. Let them join in and learn one or two things. All right. So we'll be getting straight into it. If you have any question that comes up while the delivery is going on, you will not be able to ask any of those questions at the moment of the presentation. So I'll suggest you just drop a message, drop a chat in the chat box on the Q&A section of the of Zoom. Just put it there. I'll observe for them, and then I'll ask you to speak when it's time. And then we'll be having about 50 minutes to 1 hour presentations by each of the speakers. Both of them will be speaking for 30 minutes each, after which we'll give room for questions. So we'll have the questions after all the presentations. So please sit tight and relax and enjoy a wonderful learning experience. Okay. So I'm hearing feedback. Whose mic is on? Okay. So Dr. Udu. Hi, Dr. Udu.
Hello,
Yeah,
I can hear you.
yes. Please go ahead. You can now share your screen and begin your presentation.
Thank you.
Yeah.
Good morning, everyone. I don't know if you can see my screen.
Yeah, it just came up.
Okay, perfect. Okay, thank you for this wonderful opportunity, and thank you for having me. I'll briefly talking about diabetes, hypertension, and your eyes on the clinician perspective. I said briefly because it's a whole lot delving into diabetes and hypertension under 30 minutes. Because even a year is not enough to talk about it, but I'm going to try as much as possible to recapitulate within the time given. So, on a note of introduction, worthy of note that hypertension and diabetes are two common health conditions that have serious consequences. They are the major chronic diseases there in our society today. We can't talk of chronic diseases or non-communicable diseases without talking about diabetes and hypertension. That's how important it is. And it's also imperative that we know how to take control of our health to avoid getting it or to avoid coming down with it for those of us who haven't come down with it yet. And then it's not like it's bad news for some of us who have it yet, have it already. The good news is that there are ways to go around it. So just sit tight and grab the most you can. So hypertension actually affects about 1.28 billion adults aged between 30 to 79 years. That could be a scary statistic, but the World Health Organization um, also mentioned that there are a lot of cases of hypertension and diabetes that are under check, and it means that we're actually winning the war against hypertension and diabetes. So, what is hypertension in simple terms? It has to do with high blood pressure. Now, taking it down further, you can liken it to you connecting a hose with pipe to run it tap, and then the tap is filling in the pipe from one end, and someone occludes the pipe from the other end. The pressure within the pipe will definitely build up. So the pipe could be likened to your blood pressure, to your blood vessels, and then the pressure within it would be the blood pressure that is building within the blood vessels. So hypertension occurs when the heart has to fight or work against pressure that builds in the vessels, owing to a lot of conditions which we're going to explore in the course of our conversation today. And there are lots of things hypertension can be exposed to. But before that, I would like to bring to our knowledge or notice that hypertension has two different forms. There's one we call primary hypertension and the secondary hypertension. Primary hypertension simply means that the cause is not really known. It has no exact cause. Most of them are genetically orchestrated, meaning that if it runs in your family, there is a high tendency that you're going to have it to solve. And there are also risk factors that could predispose to having the primary hypertension, which are the modifiable and the non-modifiable ones. The non-modifiable ones are the ones you have control over, like your family history and having a genetic predisposition as well. But then for the modifiable ones that are largely the lifestyle we put up help our daily living. Most times it don't really help, like smoking, alcohol intake, excessive intake of salt in our foods, and all whatnot. So these are lifestyles that are modifiable, but then they could predispose to primary hypertension when not properly checked. So the other type is the secondary hypertension, which is due to other underlying conditions like the diabetes, the chronic kidney disease, and even thyroid disorders. So it means that you can't really talk about hypertension without talking about diabetes, or talking about diabetes without hypertension. They really form an unholy alliance, which you're going to find out how they do that in the course of the conversation. So, but the good news is that I'll keep talking about the good news though, because I mean, a lot of people are scarred by the menace of hypertension and diabetes, thinking there is really no hope about it. But there's actually a lot of hope when it comes to the management, because a lot of research is ongoing and a lot of solutions is being proffered as well to that course. So the good news is that if your hypertension or diabetes is tightly controlled independently, there are less chances of you having the other. So it could be, it mustn't be the two coexisting at the same time. That can happen if you don't tightly control one when it happens. So hypertension as a form of a complication can lead to stroke, kidney diseases, like I mentioned, the chronic kidney disease, and even loss of vision. But then diabetes on the other is simply a condition where bodies are able to regulate blood sugar levels properly. It's just like starvation in the midst of plenty. Normally, when you eat, the glucose moieties are meant to be broken down and taken to your cells. The cells in the body are like the end, and they receive the sugar you take in form of carbohydrate, protein, or any form of class of food. They break them down and convert them to glucose. Glucose is usually the end product of metabolism, especially for most pathways. So when glucose molecules are produced and they are meant to be transported to the cells, because the cells are the ones that use them for various functions in the body, like metabolism, that you sleep and wake up is because of the glucose that is being transported to your cell, that you work out actively because of the glucose, but that you breathe even is because of the glucose transported to your cell. Now, what really happens is that when this glucose that is meant to be taken to the cells are not transported appropriately, they tend to accumulate in your blood. They tend to accumulate in your blood. just like having traffic in Lagos, on the Lagos Island, it's a common thing to see traffic, especially from 4 p.m. upwards. Now, there are lots of compounds in Lagos Island, on the Lagos Island. And now, most of the people on the traffic are meant to take their cars in these various compounds where they reside. Now, these compounds are empty, but the roads are very busy. Why? Because there is no free routes for the cars to get to their destination. So the destinations we're talking about in terms of your body are the cells which receive this glucose. So when the cells don't receive this glucose, the cells end up starving. Meanwhile, there are many glucose molecules floating out there in the bloodstream, and that is diabetes in the simplest of terms. So there are various types of diabetes. When you talk about diabetes, there is type 1, type 2, and gestational diabetes, which are called pregnant women. So the type 1 diabetes is known as the juvenile onset diabetes. It happens commonly in younger people, in children. What happens usually is that there is an attack on the natural insulin produced by the body. The body is meant to produce insulin, and the insulin is meant to break down this sugar in the blood and take them to the cells where they are meant to be used effectively. But then the insulin that is responsible for that is attacked by some body cells. Could be an autoimmune disease that attacks the insulin. Then the insulin is handicapped in its functions. It no longer does the usual thing it's meant to do. So it's usually genetically orchestrated. That's why it's in younger people. But then the type 2 is also known as the non-insulin dependent diabetes. What happens usually is that there is excess of insulin. The insulin is there, but then the insulin is not able to do what it's meant to do due to resistance and a whole lot of other factors. But then majorly due to resistance, also known as insulin-resistant diabetes mellitus. So in this type 2, what usually causes it is obesity, as having a large body mass. Because when the body mass is so much, the fats tend to deposit on some of the insulin receptors and blocks out the effect of the insulin. That way, the insulin is not able to do what it's meant to do. And then the other type, which is the last one, is the gestational diabetes. It's seen in pregnant women where there is a form of impairment in glucose metabolism. So their glucose level tends to be high during pregnancy, and most times it gets back to normal after pregnancy is over. Then it can also lead to various forms of heart diseases, kidney disease, and nerve damage. And vision loss is not also left out of it. So if you notice from the complications of the hypertension and diabetes, one thing was constant, the vision loss, meaning that your eyes are really in trouble if you have this condition. It's not to scare you, but it's just to make us aware of the complications thereof, and we can take proper care to avoid them. So the eyes are usually targets of these two unholy couple, so to say. So now the nexus, how do these two come together to do all they do? That's what we need to find out. And talking about the nexus, most people don't really have the two conditions at the same time, diabetes and hypertension. Remember I said at the beginning that having one of them could predispose to the other, especially having diabetes could predispose to having hypertension. Usually I tell my patients that if I'm meant to choose one, I would rather choose hypertension to diabetes, because hypertension can be independently managed without further complications. Not that diabetes can't be independently damaged, but then diabetes can affect various parts of the body. It's it has multiple complications and has multiple effects in the body. But then I don't think I'll be able to choose anyone, and nobody would want to. But then the point is that when these two eventually coexist in the body, there are lots of um, complications they end up resulting to. Now, the common pathophysiology is that in diabetes, due to the fact that um, there is excess glucose in the blood, most times there is hypoxia, and then there is increased reactive oxygen species, which end up destroying some of the blood vessels. So there is damage to the blood vessels. When the blood vessels are damaged, naturally, the way God has made it, the blood vessels have to heal. So in the process of healing, the blood vessels might get fibrous, they might get harder, and then they might also get narrower. So when they get narrower, the pressure builds up. I still take you back to the initial analogy I made about the pipe and the water. Now, remember I told you that the pressure in the pipe could build up. Now, assuming the pipe is getting water from one end and someone goes to match on the pipe, definitely the pressure is going to triple or even double or quadruple. So that way, because of the narrowing of the blood vessels as a result of the healing effect caused by diabetes and the damage it resulted to, the blood vessels might get narrower and then the blood pressure increases. That way, hypertension might ensue faster than we even expect. So there is this unholy alliance between hypertension and diabetes, and their synergism is also not far-fetched, because if we talk about diabetes and then close our eyes to hypertension, we might be making a very big mistake. That's why we always screen for both of them concomitantly when we are managing patients that have either of them. Now, there is also accelerated disease progression when both of them coexist, and also increased risk of complication. Now, some of the risk factors they share are obesity, physical inactivity, and poor diet. So obesity can never be overemphasized. And the reason I'm overemphasizing is that simple measures like physical activity and proper dieting can prevent obesity. And when obesity is prevented, this whole disease entity can actually be prevented. So we're going to talk about that more in the prevention later in the slide. So how do these conditions present? Most times people expect to have a banging headache and a disturbing sleep and very scary nightmares before they come to the hospital or check their blood pressure. No, hypertension most times don't even give you signs. It just um, comes in a very silent manner. Hypertension is a liaison and a silent killer. So it becomes on us to always check our blood pressure and do the needful when it comes to being careful about our health. So I'm here to tell you today that hypertension doesn't always come with symptoms. It doesn't always come with symptoms. Even if you don't go with any other thing today, take this home, preach it, that hypertension always doesn't come with symptoms. Sometimes it can be very silent unless you go check out the blood pressure yourself. You'll be alarmed at what you might say. So, but then sometimes you can also have signs like these headache, dizziness, and even nosebleeds. But then it doesn't always come with symptoms. Have that at the back of your mind. Then diabetes, on the other hand, has some signs and symptoms like increased thirst and urination. There is always this fatigue. Now, this fatigue is due to the fact that I told you there is starvation in the midst of plenty. There is excess of sugar in the blood, but then it's not going to the proper destination, which is the cell. So if the cell doesn't get it, there is no energy in the body, because the cells have to undergo a metabolism, a form of metabolism, to produce energy for these glucose molecules. So there is also blood vision when it gets to affect your eye, and there is slow healing of cuts and wounds. Yeah, the reason there is slow healing of cuts and wounds is that in diabetes, if you get an injury, Remember that the blood has a lot of sugar, and it's not just we humans that love sugar. Microorganisms love sugar as well. So these organisms are attracted by the sugar in your blood. So to get to the injury site and live there rent free, parents, they just stay there, and then they prevent the wound from healing very fast. That's why the wounds in people with diabetes stay there for a very long time. And it's also important to emphasize that if you have diabetes, try to avoid things that will predispose you to having a minor traumas or even major ones. Then some of the complications which I mentioned earlier, I'm going to repeat them, are heart attack for the cardiovascular parts, could be heart attack following hypertension that is unchecked. There could be stroke, and there could be peripheral artery. You shouldn't let them take your eyes. Then neurology, they have a lot of widespread effect on the nerves. Um, some people with diabetes could have some tingling sensations on their hands and feet. It's not normal. It's as a result of a neuropathy caused by the diabetes, and you really need to go see your doctor to start feeling that way. Now, I want to isolate the hypertensive retinopathy part because it forms part of our topic for discussion for today. The major complication of hypertension is worthy of mention. So it's one of the major microvascular complications of hypertension. The other microvascular complications are hypertensive nephropathy, meaning that it affects your kidneys and damages the small vessels within your kidney, and then the hypertensive neuropathy, which I already mentioned. So the hypertensive retinopathy has to do with these small vessels in your eyes around the retina. The retina is a part of the eye, and the retina has small vessels that are easily affected by hypertension. Remember that hypertension is a pressure condition, it's a high pressure condition, high blood pressure condition that has to do with the heart kicking against the resistance built by the vessels all around your body. And the vessels all around your body encompass the vessels in the eye. Encompass the vessels in the eye. Imagine blowing a balloon, like one of the very small balloons. You're blowing a balloon and you're putting in so much air, and then the balloon is stretching so thin, and you keep blowing it. What would happen? What do you think would happen? The balloon is definitely going to burst. You can liken that to what happens in the eye. When the pressure is building from the heart to other parts of the body, in the vessels, everywhere is just highly pressured. And know you that the pressure in the smaller vessels are more than the pressures in the bigger vessels. In every other part of the body, there are vessels that have more calibers than that's in the eye. The eyes have arterioles. That's arterioles means smaller vessels, smaller arteries. So that's what usually happens with your eye when you have high blood pressure. As the pressure keeps increasing, the vessels in the eye, because they are very small, they are very vulnerable to damage. That's why the retinopathy ensues. And the retinopathy ensues because the blood vessels are meant to supply or nourish the retina, the part of the eye where the images are formed. So if they don't nourish the retina, there is no way images will be formed. So it could lead to blindness. But then, if caught early, something could happen, something positive could happen. But I'll leave that to the optometrist who's going to talk about that in details. But just know that hypertension and retinopathy are inseparable. They coexist. Likewise, the diabetic retinopathy. So in diabetes, like I mentioned earlier, there is damage to the vessels. There is damage to the vessels. So the vessels in the eyes are also not left out because they also damage them. And when they damage them, the body tries to heal those vessels that are damaged, and it's of healing them by bringing up new vessels. Okay, how I want to use this analogy. Imagine having um a, you are seeing with your glasses. You're using glasses to see. You, you're using either astigmatic lenses, concave or convex lenses for your vision, to aid your vision. And then rain falls, or you're trying to use a face mask, and then you're breathing, and then some vapor go to your glasses are definitely going to blow. So there is something foreign introduced to your glasses. That's why they are blurring out. That way, in the retina, when there is damage by diabetes or the hyperglycemia induced damage, the body definitely would want to replace those damaged vessels, meaning that there are new vessels called angiogenesis around the retina. So they are definitely going to blur the path of vision, and then that's how blindness ensues. But then, if caught early and the blood sugar kept in check, none of this is going to happen. Then I also want to say at this point that when diabetes or hypertension causes these retinopathies, you are not going to treat the retinopathies or the eyes separately as an entity. The major and only treatment you can get at that point is controlling your blood sugar and your hypertension. That's the elevated blood pressure. Those are the major treatments you get to relieve this existing retinopathy if peradventure it starts. Then, how do you diagnose high blood pressure? It's very simple. It's as simple as getting your speed or going to the hospital to use a sphygmomanometer and checking it and seeing your values. That way, you can be rest assured that your values are either okay or that they are high and you need to do something about them. Then, for the diabetes, you can simply diagnose by checking for your fasting blood sugar, or you do the one they call the glycated hemoglobin, also known as HbA1c. And then for the gestational diabetes, pregnant women are usually encouraged to do the 75-gram OGTT. It's called oral glucose tolerance test, where they can check their level of glucose tolerance during pregnancy. And then other investigations or tests that can be done are the lipid profile, the kidney function test, and eye exam. Lipid profile is particularly important because the lipids or the cholesterol, as we may call it, when they deposit in the vessels, they can equally narrow the lumen of the vessels and hence build up blood pressure within the vessels. And the heart has a lot of work to do by working against resistance. That way, the blood pressure could also increase. So these are basic tests we need to do. But there are many others, including the echocardiography, the ECG electrocardiography, and name them. They are a lot, but then I would save them for a later discussion. Now, the management. There is nothing as, okay, in our parlance, we say that prevention is better than cure. So lifestyle management is usually very, very highly advocated in terms of management of hypertension and diabetes, eating healthy, having regular exercise, weight management, even stress reduction. All these culminate, if not checked, they culminate to result into hypertension. They culminate to hypertension and diabetes. And then it's important to take these aspects very, very seriously because you don't need to do so much in having a regular exercise and healthy diet. But then when you eventually come down with the disease condition, you might do more than just exercise or healthy diet. So why not choose the little one than getting the higher responsibility of having to go to the hospital frequently or even being on medication? So the medications there are antihypertensives and diabetic medication. So the use of medications are actually individualized based on your doctor's prescription and based on your blood pressure levels. There are different medications that could be titrated to suit either your hypertensive state or the diabetic state. What matters is that your blood pressure has adequate control. So for the fact that someone else is having a different set of medication from yours doesn't mean that you're not taking the right medication as long as you get them from a certified medical practitioner. Then for the monitoring, there are routine monitoring to do, especially as regards hypertensive retinopathy. Now, if if you have a type 1 diabetes mellitus, you are required to start your eye screening at 5 years after the diagnosis is made. But then if you have type 2 diabetes, that's the one that deals with insulin resistance, you're meant to start your screening at the time of diagnosis, as the eye screening. Start checking your eye as
Hi, Dr. Udo. We lost you for a bit. Hello, Dr. Udo.
hello.
Hi, Dr. Udo. Yeah,
Can you still hear me?
yeah, we can hear you now. We lost you for a bit.
Okay, sorry for the break. Let me share my screen again. Okay, my screen is open now. Hello. Can you hear me? Can you see my screen?
Yes, not as good as before, but yes, we can hear you.
Okay, all right. Okay. Yeah. So I was talking about the multidisciplinary care, which is really, really paramount, because it's really imperative not to manage this condition in silos. It's a conglomerative effort by the cardiologist, the endocrinologist, and the ophthalmologist, even the optometrist. Everyone is involved. Then prevention, like I said earlier, is better, and far better than cure. You can't talk about this condition without talking about prevention, because we don't want more people coming down with this condition. We're really tired during with the ones we have already, so we don't want more people. So we need to preach healthy lifestyle choices, like having regular exercise and having a routine, having a good diet, an adequate diet, and regular checkup can never be emphasized. Getting your sphygmomanometer, that's a blood pressure check, and having your blood pressure checked every morning at home can go a long way in saving you a lot of stress coming down with this condition. Then, as well as the blood sugar level, with your routine eye screening, which I already mentioned about the timings. I mentioned the timings you meant to start your routine eye screening. And for the stress management, there are relaxation techniques you can employ to help you relax and not come down with this condition. So that's ravaging our society today. But then it's also good to emphasize that there is good news because there are ways to prevent it, and prevention is far better than cure. So with that, I would like to summarize by saying or I would rather say that your eye is the most precious part of your body, because without your eyes, you can't see what's really happening around you. And nobody wants to lose their sight in matters of hypertension and diabetes, because the sight is as holding as you are. Thank you very much for having me. I will be happy to answer the question.
Okay. Thank you, Dr. Udu, for the presentation. Thank you for throwing as much light as possible to this, and you've done a very extensive and detailed job here. Thank you. Yes. So quickly, we'll take the second session of this webinar by our optometrist, Dr. Raphael James. Dr. James, are you around?
Yes, I am, Mr. Vina. Please, can you confirm if I'm audible?
Yes, you're audible. Just I can't see your face.
All right. No worry, you see the light from there. I think I should be visible by now.
Yeah.
All right, let me share my screen.
Yes, good. Go ahead.
I'm sharing this.
Yeah, you can use the slideshow.
You can see my screen now.
Yes, you can use the slideshow so that it will be bold.
Okay. Okay. All right. So while it comes up, I would love to appreciate Dr. what you've said. You've really done justice to our topic of discussion today. So thank you so much, because you've actually made work very easy for me. So you've laid the foundation, so I might not have to repeat myself in some of the things we're about to discuss. So it's going to make things way, 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 way easy for me. So we'll be discussing, but I think Dr. Handles some of this. So we'll just dive straight in and start. Now we discuss, why does this matter? Why are we discussing this? What is our purpose of gathering here today? So Dr. have talked about the diabetes, the prevalence, and so he has done some of the numbers on diabetes and the rest of them. But I think we should focus on the third one, that's the global vision impact. And for instance, if we should talk about vision impairment and reduction in vision that comes as a result of someone being affected with maybe diabetes or hypertension, then we'll have to run the numbers a little bit, so we'll see how important this topic is to us. Now, analyzing the global burden of visual impairments, blindness, and some relationship with diabetes and hypertension, according to the 2023 report from the WHO, they found out that at least 2.2 billion people in the world have near or distant visual impairments. And this entails that there is a considerable reduction in their vision while either looking at things that are far away from them or looking at things that are within their arm's length. So we are talking about their near and their distant vision. And they also found out that about half, which is about 1 billion of these, could have been prevented if adequate measures were taken and even addressed. So let's take a look at the pyramid by the right-hand side of the screen. You can see the leading cause of visual impairments. Now, according to their rating, the 2023 WHO report, they found out that refractive errors came first, followed by cataracts, diabetic retinopathy, glaucoma, age-related macular degeneration. Now, it's actually worthy to note that one or both of the things we are discussing today, that means either hypertension or diabetes, they could cause any of these things that you are seeing by the right-hand side. So you having any of these things has increased the risk of coming down with some of these things. And talking about vision loss, diabetes and hypertension are the leading causes of preventable vision loss. Now, not that they directly cause this vision loss actually, but they could trigger conditions that could make you lose your sight. Some of these conditions include like glaucoma, retinal detachment, and just the rest. We often think of diabetes and high blood pressure as affecting the heart, the kidneys, and the brains alone, but they are also major causes of eye diseases. And the tricky part is the eye damage, they progress quietly and they are very silent. By the time symptoms starts to show up, it has already advanced. By the time the person comes to the clinic and we do one or two things for them, sometimes we might be able to preserve what is left. And in some cases, there is really nothing to be done. So remember, you can warn with your eyes can actually warn you even before your kidneys and your heart begin to fail. So that's why it's safer to be detected in the eye than actually having the signs. Like we start having things like kidney failure, we start having strokes. So it's actually better to be detected in the eyes before it gets to this extent. So this is just part of the reason why this topic matters to us. So we're going over to the next thing which we have, and that is the eyes. Now let's talk about something interesting. How can the eye give us a glimpse into the health of the entire body? So this slide, we title it "The Eye, the Window to Your Health." And it's not just an adage, it's a medical fact. You see, the eye is the only part of the human body where you can directly observe blood vessels without needing any surgery. So you don't need an incision, you don't need to cut your skin open for us to see your blood vessels. You can actually observe them through your eyes. And now we look at the back of the eye, at the retina, we're able to see tiny blood vessels in real time. And that's valuable, especially when we are monitoring diseases like hypertension and diabetes. Now, on the diagram here, at the back of the retina, at the back of the eye is the retina, and that's the light sensitive layer. It's just like the screen where everything you see falls on. Then it's relayed through your optic nerve, which is what we have here, to your brain for interpretation. So the optic nerve can actually show changes when your blood pressure is so high. Like for example, it starts to swell, and once it starts swelling, things become blood. And if you are lucky, your eyes begin to pain you. But if you're not lucky, it becomes silent until all of a sudden the person loses their sight. So that's how some of these things they function. So the next one we have is the vitreous. Now, the vitreous tumor is is a gel-like thing that fills the center of the eye. So when the eye is placed on the floor and crushed, there is a gel that's going to spill out. And that gel is just what we call the vitreous tumor. So this is where we observe things like floaters, and when there is bleeding in the eye as a result of diabetes, this is just where the bleeding just enters and start affecting the person's vision. So the next one we have is the crystalline lens, which helps us to focus light on the retina. And it can become very cloudy in conditions like cataracts, especially in diabetes. And then we have the cornea. The cornea is at the front of the eye, and it can show changes in hydration or even infection in some advanced cases. Now, why are we saying all these things? Because we will start talking about some of these parts of the eye so that you can understand and have a pictorial representation in your memory of what it looks like. Now, if you look by the right-hand side, you will notice the icons that are surrounding the eye in the right diagram. So they represent common conditions that leave their fingerprint in the eye. Like we have the heart, the brain, the liver, the kidney, and the lungs. Any defect in one of these organs or more can have serious consequences and manifestations in the eyes at most times. And in many cases, they can affect both eyes at the same time, though the degree can vary. So when your doctor checks your eyes, he's not just looking at the eyes, but the health conditions of other parts of your body, because your eye is actually linked to other parts of your body. And other parts of your body express some things, some anomalies that are going on in them through the eyes. So we'll go to our next slide. We'll talk about some systemic diseases and your eyes. And the first one we'll talk about is diabetes. Diabetes doesn't just affect blood sugar. it affects nearly every organ in the body, and that includes your eyes. So when diabetes damages different parts of the eye, it results to a condition we refer to as diabetic eye disease. So the most significant changes that occur, it usually occurs at the retina, which is the light sensitive part, the one I said that is like a screen. So over time, high blood sugar levels, they weaken and damage these blood vessels in the retina. And this condition is what we call diabetic retinopathy, just like Dr. Wood was saying. So you often hear this referred to in stages as early and advanced stages. In the early stages, you can look at the simulation we have here. In the early stages, or what we call non-proliferative diabetic retinopathy, you see the blood vessels, they begin to leak some tiny amount of fluid. If you look at both the left and right, and if you pay keen attention, you will see there are some collections of blood spots here and there. So this is the eye, the blood vessels, they are beginning to leak blood. And this blood, when it leaks outside these blood vessels. And in this stage, the retina leaks these things, and there might not be symptoms at this point. That is why regular screening is very important. Now, as the condition progresses, it becomes what we call proliferative diabetic retinopathy, which is the most advanced stage. At this stage, you see the retina starts to grow abnormal new vessels. If you look at the simulation, what we have here, you see at the upper part, you see new blood vessels are growing. Why are these blood vessels growing? They are growing to absorb those tiny bloods that have been spilled out of the blood, the central retinal blood vessels. So your eye will respond by creating or forming new blood vessels to absorb this leaking blood. And the problem now is that these vessels, they are very fragile and they tend to bleed easily into the vitreous. And for example, you can just wake up abruptly or just shake your head, or you can just bend down to pick something, then they rupture. Once they rupture, they even pour more blood. They just give up more blood in the vitreous, and that's going to affect the person's vision. And when this happens, it causes sudden obstruction in vision. You see some people start experiencing this red, brown things over whatever they are looking at, or you see some dark shadows obstructing their vision, just like you can see the bed there moving, but you can see some dark shadows. Those are just patches of blood that are blocking what he has seen. So as they are looking at the bed, the light coming from the bed is being obstructed by these blood vessels, and you just start seeing some of this. That's why we see some patients say, I'm seeing something in my eyes, as if there's something is moving inside my eye. If I move my head, it moves. Then some people, if they are lucky, they will have this brown or red tint over what they are seeing. That's actually a very serious thing. So that is for that. Then diabetes can also affect other structures in the eyes. For example, the lens. It could result to fluid retention. That crystalline lens that we told you that help to focus light on the retina, it can make it to swell. And once it swells up, then your vision becomes blurred. And anytime your blood sugar level comes down, it goes back to the normal level, and your vision becomes well. So anytime you start experiencing things like fluctuating vision, that means there is something really going on in the eyes. So another place it could affect is the iris, where we see abnormal blood vessels grow. And this is something very serious. Though it's rare, but once it happens, it can obstruct the one small hole where fluid is being drained out of your eye. So once it blocks that place, it results to what we call angle closure glaucoma. And that is sight-threatening. And if nothing is done within hours, the person can lose their vision permanently. So that's for that. So one of the most vision-threatening complications is that apart from this glaucoma, is the macular edema, which is the swelling in the central part of the retina, and it affects the sharp central vision. And people start having blurred vision or distorted vision, where straight lines now start appearing as though they are curved. So some people will start noticing little obstructions in their field of vision, like floaters. Some may experience flashes of lights, which is a serious sign indicating that something very serious or vision threatening is happening behind the eyes. So ultimately, if diabetic eye disease is not detected and managed early, it can lead to partial or complete vision loss. And And that loss can be temporary, permanent, depending on how soon it's treated. So the loss of vision is usually progressive as the retina detaches. So from where it's attached in the eye, like I think we have something like that. If you watch the simulation, you see at the upper part, you see the retina is being retracted, and as it's retracted, it's detaching from where it's being attached, and that is a very serious thing. So as it's detaching, you are losing your vision in that area that is detaching. Then what happens if you should detach from every of its point of attachment to the choroid? That means the person goes blind. So once this thing start happening, you start seeing people complain of, it's as if there is curtain is closing in my eyes, like there is as if I'm looking through a window and there is a curtain covering it. That's because that area that is as if there's curtain there has been detached, and that's what we call retinal detachment. So the key takeaway here is eye disease, diabetic eye disease, they progress silently, and the damage can be happening even before symptoms appear. That is why regular dilated eye examination is compulsory for every person with diabetes. Now, let's just briefly look at the signs and symptoms of diabetic eye disease. What should we look out for? So the danger is that most people have no symptoms, just like we've been repeating, until the damage is advanced. But if you notice blood or fluctuating vision, floaters means you start seeing some things moving around, but no other person is seeing it. You are just the only one seeing it. Or you start noticing dark spots, don't ignore them, please. This could be sign of bleeding or swelling in the eye. Also look out for flashes of light, as it could be a sign of ongoing retinal detachment and ultimately sudden vision loss. So that's some things you can look out for if you are diabetic. Now we discuss on hypertension. So just like diabetes, hypertension or high blood pressure has a significant impact on the eyes. These changes, they occur silently, just like the hypertension, without any early symptoms, making it even more important for a regular eye check for people that are hypertensive. So the most well-known condition linked to high blood pressure is what we call hypertensive retinopathy. This is where that is just hypertension affecting your retina. That's what this program is. So when your blood sugar starts affecting the retina, which is that screen in your eyes that send information through the nerve, which is the wire to your brain for interpretation. When diabetes start affecting that tissue, is what we call hypertensive retinopathy. So this is where the retinal blood vessels, they become narrowed and they become hard due to long-standing pressure and resistance to the blood. So over time, this can reduce blood flow to the retina and even cause leakages or even small bleeding. In the early stages, we might see silent signs like narrowing of the arteries, tiny hemorrhages, and cottonwool spots. Cottonwool spots are those small things that we saw in that simulation, those white things that are just around there. So in more advanced stages, blood vessels may even rupture and they leak fluid into the retina, leading to vision loss. Another lesser known one, which is a very important condition, is what we call the dry eye disease or DED. So hypertension can impair, it can reduce the blood supply to the lacrimal gland. That lacrimal gland is the part of your eyes that produces tears. So when blood supply is cut short, getting to that thing, it makes your eye to produce less tears. And that's why you start seeing people having symptoms like eye irritation. It's as if there's sand in their eyes. We usually have those patients. They'll tell you that they've tried many eye drops, but every time it's as if there's sand in their eyes. They keep washing their eyes and the sand doesn't go away. That is because not that there is sand in their eyes, but their eyes are no longer producing enough tears to help lubricate the surface of their eyes. And because of that, they start having that sandy sensation and blood vision. So prolonged high blood pressure can also affect the optic nerve, which is the wire that connects the eye to the brain. It can reduce blood flow or even swelling of the optic nerve head. And this can lead to permanent vision loss if not addressed immediately. So if you say permanent here, we actually mean permanent, like there is nothing, there is no remedy at all, not even surgery can restore the person's vision. So again, the key message here is that hypertension can cause real and sometimes irreversible damages to the eye. And these changes may go unnoticed even without a proper eye examination. So this highlights the importance of regular eye check, not just for your vision, but for monitoring the health of blood vessels throughout your body. So that's just for hypertension. Now we talk of the signs and symptoms. Now, one of the biggest challenges with hypertension related eye problems is that they often develop silently. We'll keep repeating this so I can get into the minds of people. Most people, especially in the early stages of hypertension, hypertensive eye diseases, they report no symptoms at all. That's why it's often classified as one of the silent threats to vision. So, however, as the disease progresses, or during hypertensive crisis, you may begin to notice certain symptoms. The most common one is blood or dim vision, which might come and go or worsen gradually. Some people may experience headache that is associated with changes in their vision. This could be a red flag, especially if your blood pressure is high. In some severe emergency cases, such as malignant hypertension, there can be eye pain. So this is just one of the rare times when it will give you sign of pain. So that's why I tell people, anytime you start having serious eye pain, that is not as a result of something hitting your eyes or something scratching your eyes, then it's possible that something very serious is going on in your eyes. Because most of these ocular pathologies, some of these things that happen in the eye, they don't even come with pain. You don't even know that something is happening to your eyes until the day it goes. Now, additionally, if the high pressure affects the nerve that supply blood to the muscles that controls the eyes, you might notice things like double vision or trouble moving your eyes altogether. And now this reminds me of an event that occurred a few years back when I was working with the state government. It was towards our closing time, I think so. So we had this patient that came in. Actually, not coming, he was brought in because he didn't even know where to go to. So when he came there, I could see the anxiety in his heart. He was so much afraid. And he didn't even know how to express himself because he was shocked that his eye is moving without him moving the eyes. One of the eyes is straight, but the other one is silently moving out and deviating. So he was so much afraid. And people around him, they told him, look at your eyes, what's happening? This one is deviating. He went to the mirror and now saw that his eyes, they are now going apart, they are separating from each other. So it's just funny, but it's not funny. So he ran to the clinic and during intervention, we found out that he had serious elevated high blood pressure. He's actually lucky. It did not cause an infarct or it did not cause maybe blood clot in the brain that could have led to stroke. So that's what usually happens when blood pressure is too high to the extent of affecting the blood supply to the muscles that controls the eyes. Now, these signs, why not specific to hypertension alone, they should always prompt further evaluation, especially in people known to have high blood pressure. So the key message is, even if the eye feels fine, damage may still be going on beneath the surface. And when symptoms do appear, they may signal even a more urgent problem. So that's for this. Then we are just trying to hit some of these things, then we'll summarize. And now let's talk about prevention and standard guidelines. How do we prevent these eye manifestations of hypertension and diabetes? What is within our control and what is outside our control? So the most powerful tool we have against diabetes and hypertension related eye diseases is just prevention. And the good news is there's a lot we can do. So much of it is under our control. So if you can just do one or two of these things, then we'll be fine. And it's just very simple. It just requires you to just dedicate yourself to this preventive measures. First and foremost, importantly, one, keep your blood sugar, your blood pressure, and the cholesterol under control. These are the three major players in protecting both the small and large blood vessels in the body, including those in the eyes. I don't know how we can emphasize this. So secondly, we have the lifestyle changes. They really make a very big difference. Like we have things like quitting smoking is essential. Smoking actually speeds up the blood vessel damage and raises the risk of diabetic and hypertensive eye complications. So we have regular exercise, regular exercises, regular physical activity, even just walking, it improves blood flow and lower stress, and even help with blood sugar control, because if there is excess sugar in your blood and you exercise, so other parts of your body just burn that sugar. So it reduces the concentration of the sugar in your blood by just exercising alone. So a balanced and low sugar, low salt diet, it supports both your health and your eye health. So thirdly, after taking, always take your medications exactly as prescribed. Even if you feel fine, skipping doses can lead to silent damages, especially in the eye. We've had many patients that they come to say, Doctor, I've been checking, I even have SFIG in my house. I'm taking my drugs, my blood pressure is fine. So is there any need? I'm tired of taking. I told them, how big is your hypertensive drugs? They say, just one tiny thing. I say, you're lucky that you're just taking one or two of these drugs. There are people that live all their life and taking very big, voluminous amounts of drugs. And they are happy because it's sustaining their lives. But see, it's just this small thing and you're finding it difficult. And the problem is not taking some of this medication. You might feel right, but you don't know that there are silent damages that are going on in your eyes. Then finally, and this can't be stressed enough, get a dilated eye examination once a year. So dilating the pupils allows us to look directly at the retina and the optic nerve, where early damage can be seen before vision is even affected, or other things like stroke, kidney failure even comes to play. So catching the problems early allows for earlier interventions and better outcomes. So remember, prevention is really powerful, and that's the most important thing we have control over. So small daily action can protect your vision for a lifetime. So the key factor here is intentionality. You must be intentional with the lifestyle if you want to stay in good health, even with these conditions. So I hear people say something. I hear people talk about gym. Yes, gym play a very important role with the risk of you having hypertension or diabetes. For example, if your parents are hypertensive or diabetic, there is a high probability that you're going to be hypertensive or diabetic. But remember, like someone used to say, gene only loads the gun. Then it's the lifestyle that pulls the trigger. So if you don't pull the trigger, nothing happens and everyone is safe. So that's for the prevention. And we will go into this and our general guidelines. Now, let's look into some of the guidelines as it pertains to hypertension and diabetes and the eye. So when should someone with diabetes or high blood pressure check their eyes? These are general screening guidelines we follow, and they are designed to catch problems early when they are still manageable. So if you are diabetic, a dilated eye examination is recommended every year. This is non-negotiable. Even if there is no symptom or there is no vision anomalies, you're not experiencing any problem with your vision. Remember, diabetic retinopathy can begin silently, and early changes are only detectable with a proper examination. Now, for people with hypertension, eye exams are recommended every 1 to 2 years. The frequency may vary depending on how well controlled your blood pressure is and whether any changes have already been seen in the eye. So that's just it. So if you have already been diagnosed with retinopathy or other eye issues, then we may recommend more frequent follow-up, sometimes every few months, depending on severity. And there is a small but important tip that makes a big difference, and that is always bring your previous eye examination reports to the clinic appointments. This helps your eye care team monitor progression, compare the findings over time, and even make better diagnosis for your overall care. So this is just one of the limitations of people that jump from one clinic to another. We've had people, I used to have some patients, I had some patients different times. So during clinic, we asked him, are you hypertensive, are you diabetes? He said no. So when thank God, we usually take their vitals even before doing eye examination. So we found out that this patient's blood pressure was like, Madam, are you hypertensive? She says no. I say, is it by faith or you just claim it? Like she say, they told her that she has hypertension. The truth is that they told her she has hypertension and it was affecting her eyes, But she did not believe, so she was busy jumping from one clinic to another to see the one that will give her that diagnosis that no, it hasn't affected your eyes. And that's one problem, because you will not have these reports. And because of it, there is no way your medical practitioners will be able to give this comprehensive continuity of care, in the sense that, oh, we've seen how your eye was 6 months ago, and now you're here again. So we have something to compare. But because they jump from one place or the other, there is nothing to be compared with. So at last, they will still be at the losing end. So think of eye screening as part of your full body checkup. It's not just about seeing clearly. It's about catching early signs of vascular damage before it even leads to serious complications. Now, and finally, what are we taking home today, and what comes next after here? So that's what we talk about, our takeaway and our action plans. Let's wrap up with just a few points and important takeaways. First, both diabetes and hypertension can cause serious, often silent damage to the eye. By the time symptoms appear, the damage may already be advanced. Second, regular eye examinations are not optional, they are vital. Even if you feel fine or see well, problems could still be developing beneath the surface. So a yearly dilated eye examination is one of the best tools we have to protect your sight. And finally, it all comes down to this: good control of blood sugar, blood pressure, and cholesterol, combined with early detection. It gives you the best chance of preserving your vision for life. As I summarize, I want to leave us with this very simple action plan, just 3 steps to protect your eye health. Step 1, book your eye examination. Whether you have had one recently or it's been a while, make sure it's on your calendar, especially if you have diabetes or high blood pressure. Remember, no symptoms doesn't mean no problem. You can have symptoms, you cannot even have symptoms, but you're having serious problems going on. Now, step 2 is manage your numbers. Keep your blood pressure, your blood sugar, your cholesterol within target ranges. This helps protect the blood vessels. I don't know how we can overemphasize this in your eyes, and not just in your eye, keeping your blood vessels healthy. It can keep your blood vessels in your kidney, it can keep your blood vessels every other part of your body, and it keeps them healthy. Step 3, follow up regularly. If your doctor recommends 6 months or even yearly examinations, please stick to it. If you already have eye changes, you might need to come closer for monitoring. And that's okay, because early detection leads to better outcome. It's not complicated, but it does require consistency. I know sight loss can be scary most times, but the truth is, many of these cases we see today could have been prevented. And if you do just one thing after today, let it be these plans that we just listed here. So thank you, and remember, let's continue to prioritize our eye health as part of the whole body health. So as you're taking care of your body, please still take care of your eye as well. Thank you, and that will be all for now. Thank you.
Thank you.
So
Yeah. Thank you, Dr. Ravi. It's been very great with your presentation and Dr. Udu's presentation. Dr. Udu talked about the unholy couple. And I think one of the beautiful ways you presented it, I like Dr. Rav, is he said, genes load the gun and lifestyle pulls the trigger. Yeah, that's a beautiful capture of a lot of information. Thank you very much. And I hope our audience have learned a lot, and I'm sure they have found a lot of value from the presentation today. So I have a couple of questions, and I think just two for now. But I will start with this. This person says, I think continuous taking of a particular drug may result to some effect. So how can we possibly check such effects for we that are in such conditions? So maybe this person is already having a chronic condition and is on a continuous drug therapy, and he feels that the continuous taking of a particular drug or some of those drugs may also have some effect. Then how do they check and perhaps manage this? Um, so Dr. Rav, Dr. Udu, do you want to try this? Okay, Dr. Rab, go ahead. Your
All
hand
right,
is
let
up.
me question. Yeah, I understand the continuous taking of a particular drug may result to some effect. Now, because the person should have thrown light or more light on what kind of medications. Yes, we know that some medications for management of hypertension can predispose a patient to risk of having dry eye syndrome, dry eye diseases. And there are some researches and there are some project works with some researches and presentations we've done in our clinics here in UHA clinics that helps to to sensitize our doctors and help us to streamline our medications. Now, it depends, one, but the thing is, most of these drugs, they don't cause damaging effects of maybe optic neuritis or bleeding in your eyes. No, they will not cause this. But the only thing I know some of these drugs can cause is just dry eye syndrome. So I would have appreciated if the person has shedded more light on the medications they are talking about. But the truth of the whole thing is the management for these things, for them to not to have ocular manifestation, is just following your treatment. Moreover, if you are taking a medication and you find out that you are beginning to have some symptoms, please, it's advisable to go back to your doctor, go back to the physician where you are being managed, and and tell them, then they'll do a drug review, and if there's any need, they can give you another class of medication that might not have that symptom. So thank you. I don't know if that does justice to the question.
Yeah, it does help a lot. I believe the person here speaking. Dr. Odu, would you want to share a thought on that as well?
Yes, please. I just wanted to add, every drug has a side effect. Yeah, because drugs they're poisonous, but then they're harnessed to suit the needs of our health. So every drug has a side effect. And on the other hand, there are also idiosyncrasies, meaning that people react to different drugs in individual ways. So that someone could have side effects from a medication doesn't mean that another could have it. So it's important to have these complaints early and report them to your physician so they can find a better alternative for you. That's just what I wanted to add. Yeah, thank you.
Okay, yeah, thank you, Dr. Odu. Dr. Odu is suggesting you're specific and not let us not just make a general cover as to reactions to drugs. All right. Um, so okay, so I think the same person is asking that the drug is referring to, but I think that question has been answered. He says amlodipine and hydro are the drugs. But I think Dr. Idu said if you notice anything, you discuss directly with your doctor because the reactions could be different from individual to individual, right? And then somebody else is asking, is there can long-term management of glaucoma with beta blockers lead to issues such as dry eyes? Dr. Ram, I think you mentioned something about dry eye. Dr. Ram, hello?
Oh, sorry, I thought I was still unmuted. Yeah, I'm still here.
Yes.
So yes, actually, long-term use of beta blockers, they can actually cause dry eyes. Studies have shown that beta blockers, they reduce tear production and they affect the lacrimal gland and they reduce the secretion of tears over time. Now, the most important thing that might have led to that, not just beta blockers, are preservatives. So that's preservative like BAK. BAK is what we call benzachomium chloride and is a common preservative that is usually used in most eye drops. That is why for glaucoma patients, the way we do manage them here, we try as much as possible to prescribe medications that does not contain BAK because BAK they have ocular manifestation. They interfere with the corneal integrity. That's ocular, that's clear screen in your eyes that helps you to see. So those BAK, they affect they affect the way they function, and they affect the tissue, and you start having things like corneal toxicity. So that is how this thing. But for us, how we do is, and now in current practice, we have preservative-free anti-glaucoma medication. So that goes a very long way to reduce the effect of beta blockers. And now we even have better classes of anti-glaucoma drugs that we use that are not actually beta blockers. So like we have the latanoprost and the rest of which we just use once a day, and most of them comes with, they have some of them have polypod as the preservatives, and more benzalkonium chloride. So now the pharmaceutical companies, they are trying to look for a way to phase out the use of BAK for this terminal or these medications that require long-term use, like glaucoma. So most anti-glaucoma drugs that are being produced, they try as much as possible to phase out the use of BAK, benzalkonium chloride, and they use either polypod or they make it preservative free. The only thing is that they are more expensive than them. So yes, it's very true. Long-term use of beta blockers, they can affect the tear production and lead to dry eye syndrome.
Okay, thank you, Dr. Rao. So it seems we no longer have a question. So this person is asking, what is the recommended periodic check for astigmatism?
Okay, the recommended periodic check first. That's a very nice question anyway. So astigmatism is a refractive error. What do I mean? It's an error that has to do with how your eye bend light to hit a particular point in your eyes. So it's like a structural thing. I wish you can go back to that eye model. I would have explained more. So the recommended time where you just have to go back for your check for astigmatism just once every year, please. Just once every year is enough. So it's really not an ocular emergency that might require you to be visiting the clinic every time. It's just once every year. Why we are going for once every year is, one, we will do a review, possibly repeat the refraction, and see if the degree has reduced or increased, or we need to change your glasses. But that's just for astigmatism. So for every refractive errors, not just astigmatism, myopia, hypermetropia, and astigmatism, and even presbyopia, we recommend once every year. So once every year should solve the problem.
So that's the same during the annual health check, perhaps.
Yes,
All
annual
of that can be checked.
is the best time to do most of these things.
Okay. Then another person is asking, kindly shed more light on the emergence of floaters in middle-aged adults without any known history of hypertension. Did you get the
Yes,
question? Okay.
yeah, I got it. I can see it clearly here. Now, just like we were saying during the presentation, some of those symptoms and signs we've listed, they are not particular to hypertension or diabetes. Now, high floaters is a different ball game altogether. So one must understand how these things comes to be. So we talked about that vitreous gel. You see that gel-like thing that I told you, that if you throw your eyes down and step on it, it will squirt one liquid. It's just like a gel there. Now, that gel they contain collagen, and because of that, it usually breaks down. It's a living thing, so it breaks down and renew itself. So for some reasons, if it breaks down, it will not break down to just leave the eye. It can break down without breaking down completely. So that's why we start having some of these floaters around. So sometimes, why floaters are related to some serious eye condition, sometimes it can just depend on how your body tends to break down some of these things. So there are some people that it doesn't have any problem, no problem at all. It's just floaters they have. So by the time we do this comprehensive or dilated fundoscopy, that's eye examination, we'll put an eye drop so that we'll have a very wider view of the internal structures of your eyes. Then by the time we do that, we'll find out that if you find out that no other thing related to your retina is there, then that means you're just having the floaters as a result of incomplete dissolution of the collagen fibers of the vitreous humor. So it's possible for someone that doesn't have hypertension to have floaters, but if we check and there is no retinal tear and the person never had any accident or anything that hits the eye or any blunt trauma to the eye, then it's possible that it's just how it's been metabolized and catalyzed in the eye. So for that reason, we actually tell the person, okay, see what you're going to, you either get used to it, or there are some recent studies that show that people that take pineapple in large quantities, I wonder the amount of pineapple you take that will help to break that down. Then if it's disturbing enough, that's why we might have to refer or recommend to the person to have things like laser surgery, where laser pointed at those fibers that just remain and burn them off and just vaporize them. So it's possible for someone without hypertension to have floaters. But to be on the safer side, we recommend to go to eye clinic and have full dilated fundoscopy so that we can rule out every other possible cause of the eye floaters. Thank you. I don't know if that sits well.
I want to believe so. Okay, so I just want to inform those who have attended the webinar that there's a survey. There's a survey link in the chat area. You could just please help drop a comment on how effective our speakers have been in the handling of this topic. So we're a little over time, 5 minutes over time. So I'd like to give first Dr. Udu maybe 1 or 2 minutes to give final words and counsel to those who have attended the webinar. Then we'll come back to you, Dr. Raf, and then we'll round up the session. Dr. Udu, please. Hi, Dr. Udu, can you hear me? Hello, Dr. Udu. All right, Dr. James. Maybe we'll just take final words, final counsel to.
All right. Final words of presentation is just the same thing we've been saying all this while. Vision loss. And vision loss is terrifying. We know, but most of these things, they are within our capabilities of what we can handle, especially towards the area of prevention. And just like we said, the genetics, even if your parents had some of these things, they play a role, but it's your lifestyle that determines if you actually come down with some of these things in most times. So final take is, number one, try as much as possible to book an eye examination. If you're hypertensive, if you're diabetic, go to your eye doctor and request for a dilated eye examination. It's very important. It can save you a lot of money, it can save you a lot of stress, it can save you from sleeping in the hospital bed for years. We've had many people give testimonies of, I never knew I had brain tumor, I never knew I had brain cancer just by going for a simple eye examination, and some of these things we are spotted. So on the final note, please treat your eyes the same way you treat your general health. So as you're taking care of yourself generally, please take care of your eyes as well, because once you lose your sight, everything might become distasteful. Thank you so much, Mr. Obina.
Well, thank you, Dr. Raf. Very fine words there to end. So, Dr. Udu, do you have any final words to share with us as we round up? Yes.
Okay, yeah, thank you. Thank you very much. So it's important to note that you don't have to wait for these disease entities to get to your eye before you start taking precaution. Don't wait to that level. And secondly, you since these disease conditions have formed an unholy alliance to affect us, we also need to form a holy alliance ourselves to distract it. So spread the word against diabetes and hypertension. Thank you very much.
Thank you, Thank you, Dr. Udu. Dr. Udu said we should form a holy alliance against the unholy alliance between diabetes and hypertension. So I think it's been a very informative session this afternoon. Thank you, Dr. Udu, for your time. And thank you, Dr. Rapto. It's been very, very great having you guys. And to all our audience who attended this webinar, I want to thank you for your time. And I believe you found a lot of value from the information we've gathered here. So please feel free if you have any further questions that need clarification that you may want to get input on, you can shoot a mail to academy@eha.ng. Academy is ACADEMY, then at eha.ng. And I'll forward those questions to either of Dr. Udu or Dr. Raf, as the case may be, and you'll get the required responses. So until we come again your way with another very informative session, let's have a productive day ahead. Bye, everyone, and keep being healthy. Bye.